Good morning, everybody. Thank you for inviting me for such a nice conference, such a nice program that's been laid out. Thank you to my friend, Dr. Felipe, for involving me in the recent advances in AKI two-day course. I attended the course yesterday. It was an amazing talk, and it's so nice to see the expert talking about various facets of AKI and RRT. My talk today is actually a fluid overload and adverse outcome. And I pose this question to the audience: does the current evidence endorse the causality of the fluid overload in the setting of AKI and adverse outcome? I'm both adult and pediatric nephrologist. I have 11 years training, combining both. And I practice adult in Cleveland Clinic, Akron General, and pediatrics in Akron Children's. Now, if you see the pediatric acute kidney injury roadmap, there's a lot of advances in the last decade. As Dr. Philippi was giving a talk, introductory talk on epidemiology yesterday, he was right. We are identifying the entity of the AKI is defined now. More recognition has been given to the pediatric AKI. To an extent, now we identify a neonatal AKI, more advances in the definitions. If you look in 2010 and 11, which is just only 12 years down from now, the concept was developing. There was some interest group with the PCRRT, where they lay down the registry, they lay down the guidelines, which is now advanced to PCRRT Iconic, which is an international platform involving both pediatric nephrologists and the pediatric intensivists. Renal angina concept was developed. Then 2012 to 13, there was machine which was coming up, Carpedium, Nidus, Equadex. Then there was a validation of renal angina index. And overall, the new definitions of the quantification of the AKI was coming up, like P-rifle criteria, ECHAN, KDIGO guidelines. And then 2014-15, we have seen evolution into NINJA, and IKC was established. KDIGO AKI guidelines were developed, where pediatric was given a special section. New filters, a smaller filter with HF20 and CRRD was used or was placed for the use reports in the infants. Then if you see 17-18, there was neonatal awaken study, where I'm one of the steering committee member and also involved in the research. I have multiple publications in that group. Then pediatric aware study came in. Then we have pediatric SLED and SLED-F reports evolving, which Dr. Sethi has mentioned very well yesterday. And then now it's 2020 onwards, where we have now PCRRT Iconic platform, where we are developing guidelines involving multiple specialty, multitude facets into the AKI, where people are learning, and we are giving some recommendations in the form of guidelines. Fluid overload and assessment is very important. When you talk about fluid overload, I think you should know some of the definitions, like what is daily fluid balance? Daily fluid balance is daily difference in all intake and all output, which frequently does not include insensible losses. Cumulative fluid balance, sum of each day fluid balance over the period. Fluid overload, which usually implies a degree like a pulmonary edema or peripheral edema. When you talk about fluid accumulation, it's a positive fluid balance with or without linked fluid overload. Percentage of fluid overload adjustment for a body weight, it's actually a cumulative balance that is expressed as percent. A cutoff of 10% has been associated with increased mortality. Now, this is a paper, nice review that we published in a fluid overload in critically ill patient, and there is an evidence which has purported a relationship between mortality and fluid overload, which can be validated by prospective randomized controlled trial. The current literature does demonstrate that clinical significant degree of fluid overload could be below 10%. The lack of standard method to assess fluid balance and universal definition of fluid overload are issue that needs to be addressed. To date, the impact of early goal-directed therapy and utility of hemodynamic parameters predicting fluid responsiveness remains unexplored in the pediatric resuscitation. Now, when you look around the fluid overload, what are the reasons that can contribute to the fluid overload in the setting of AKI? You have positive pressure ventilation. There's an activation of renal angiotensin system, non-osmotic control of antidiuretic release, You have SIADH, oliguric acute renal failure, obligated intake and relatively oliguria, congestive heart failure, pulmonary hypertension, complex heart disease patients, prolonged immobilization, deep sedation, neuromuscular blockage. So it's a vicious circle how these patients which are critically ill can actually contribute or can develop fluid overload. What's going to happen? What will be the impact on the organ function with spatial pediatric concentration? Fluid overload is associated with increased mortality and longer duration of mechanical ventilation in critical patients. Multiple studies, which I'll show you in the further slides. Intra-abdominal hypertension and abdominal compartment syndrome due to underlying inflammatory state and capillary leak fluid balance. Very important in the setting of the bone marrow transplantation, patients going into complex cardiac surgeries. Delayed wound healing, because fluid overload in post-surgical patient leads to poor wound healing and tissue necrosis. The biggest thing is the pharmacokinetic and pharmacodynamics, which altered the volume of distribution and increased total body water, can result in a less amount of antibiotic available or medication dosage. And acute kidney injury, it's unclear if fluid overload is a cause or consequence, or it's a confounder of the AKI in ICU. Another question comes is about the quantification of fluid overload. This is a nice chart where we have multiple studies which shows, and they have taken multiple definitions for fluid overload. What the percentage fluid overload involved is fluid in, fluid out, and mission weight into 100. Now, is that right? Are you using that formula, or you can use other formula which is more based, a more practical weight-based method can be used as an alternate for the fluid overload. Percentage of fluid overload is daily fluid intake, total output, baseline body weight into 100. Now, this is a formula which is used mainly at the time when you're starting the CRRT, which is now terminology is KRRT. So it's KRRT initiation rate minus hospital admission rate divided by hospital admission rate multiplied by 100. Or if the patient is in the ICU, you can use CRRT initiation rate, ICU admission rate, or divide by ICU admission rate into 100. So these are some of the variables. These are some of the ways that you can quantify the fluid overload. I generally like the way it is daily fluid intake to the total output by baseline body weight. Definitely when I use the CRRT in the setting of fluid overload, I combine at the time when the CRRT is initiated, the weight minus the hospital weight, admission weight divided by the hospital admission. But again, this is an issue with any kind of fluid overload. As I have shown you, multiple studies have used different formulas to calculate the fluid overload. Whatever works for you, however you can assess, whatever parameters you have could be used to assess the quantification for the fluid overload. Now, there's a new evolving trend coming up that we now have to correct the serum creatinine for the fluid overload, because it refines the diagnosis of AKI and reveals the diagnosis of otherwise masked, which is uncorrected serum creatinine, which could be diluted because of the fluid overload. And this is an adjusted creatinine, which is serum creatinine parenthesis 1 plus net fluid volumes divided by the total body weight. And you all know that total body weight is around 0.6 into weight into kilogram. So you have to quantify the fluid overload, you have to adjust the serum creatinine, and maybe the dilution factor need to be corrected because it will change the severity of the AKI. Suggested reading, I will suggest you all to read the Critical Care Pediatric Nephrology Dialysis Handbook. This has been released around like 3 years now. Now, this is what the new platform of the international collaboration of nephrologists and intensivists is, because now we are taking this platform into more international level and incorporate help in preventing or saving lives, young lives all around the world. And I would like you all to please join PCRRT Iconic as a board members, as a member to initiate and dissipate the knowledge. Now, from this book, again, what are the clinical findings of fluid overload? Physical findings are there. You have some hypertension, you have tachycardia, tachypnea, gallop, JVD, Rayleigh tachypnea, decreased breath sounds, hepatomegaly, ascites, edema. What are the lab findings? Elevated BNP, low BU and low creatinine because of dilution, and again dilution anemia, hypoalbuminemia. Now we are also growing into now new concept. What we have recently published a book on POCUS, and this is something I learned over the time, how you can look into the various available techniques to assess fluid overload. Lung ultrasound, you can see extravascular lung water through the B-line artifact. You can assess the IVC. You can look into the BNP and NT-proBNP, although it's unreliable in a patient with heart failure and acute kidney injury. Bioimpedance vector analysis, where you can assess the total body contact. You can use increase in the extracellular water, low resistance to include increase of the fat-free mass. And B-lines, hyperechoic artifact radiation radiating from the pleural surface to the lung interface, which is perpendicular to the probe. There is a book that we have published on the POCUS through the PCRRT iconic. I will recommend all the fellows to please read. And this is a growing branch, and we have upcoming meeting in June where we'll be doing a virtual meeting on POCUS, and I will ask you all to please attend that. Now, maybe we are moving more forwards after talking about the formula, how to correct. Now we may need to have a quantification of fluid overload and divide this AKI with fluid overload. Grade 1, 0 or 1, fluid overload less than 10. Grade 2, corrected AKI stage 0 or 1, but fluid overload more than 10%. Grade 3, AKI corrected stage 2 creatinine with fluid overload less than 10. And when you have stage 2 or 3 more than 10%, then it is grade 4. To perform proper adjustment, we support the correction of creatinine by fluid balance to determine the correct AKI stage and also incorporate fluid overloads. And this is what the concept we have published in our AKI bone marrow transplant guidelines with PCRRT. This is what now we have. This is a paper in Advances in Pediatric Acute Kidney Injury, Risk, Damage, GFR, Kidney Failure, Death. Unfortunately, most of the time when we were consulted, it's between kidney failure and mortality and morbidity. If you look into the P-Rifle, KDIGO, Akin criteria, all have shown that the odd ratio of death is pretty high when they're stage 3. Maybe we need to work upon damage and GFR decrease. Apart from having the biomarkers, maybe the renal angina index, fluid overload, frutamide stem as the stress test, other parameters, renal reserve test can be done early to prevent the patients who are at the risk going to damage and eGFR decrease. This is new paradigm. This is new advances in pediatric AKI. Maybe we need to readdress the definition. Maybe we have to bring the concept of other non-urine or the serum markers and take into account to address the patients who will eventually lead to AKI. We are not very successful with biomarkers. We are not very successful with serum creatinine as a biomarker. Maybe we need to look into other parameters to assess the risk and further prevent the damage in eGFR. This is a paper we actually published with, what we did was we combined the fluid overload with an AKI. This is a very nice paper which shows fluid over and renal angina index with the worst outcome in critical ill patient. And you can see that maximum fluid overload is associated with the peak oxygen index. And you can see it's lower, the more higher is the fluid overload. And this is fascinating. If you see, most of the fluid overload is mainly the first 7 days. And here we see the regression coefficient less than 5, 5 to 10, 10 to 15, and more than 15. You can see the issues with the peak oxygenation, mortality, and combining it with renal angina index. In nutshell, number of children reaching peak fluid overload from day 1 to 7, mainly day 2 to 3, it shows fluid overload more than 15%, combining with renal angina index is the worst outcome. What will be an impact of a fluid overload? It's contingent about revised Starling law, which ascribes an important role in the endothelial glycocalyx, which maintain an intact vascular biology. So it's a web membrane-bound glycoprotein and proteoglycans on the luminal surface of the endothelium that binds to the plasma protein and effectively exclude protein from subendothelial cleft. therefore result in low oncotic gradients between plasma and cleft, which opposes trans-capillary efflux. What a beautiful concept. When you have a volume expansion, which is shown to promote the glycocalyx disintegration, reduce the lymphatic drainage through release of the natriuretic peptides. In addition to that, membrane-bound proteoglycans and glycoprotein, mainly the cytokine-1 hyaluronic acid of the endothelial glycocalyx, they all reduce the lymphatic drainage by inhibiting the lymphatic propulsive motor activity. This versus the fluid overload, because interstitial fluid is the primary channel back into circulation via the lymphatics. This is a nice diagram going back to our physiology, and you can see that the superimposition of the Frank, Starling, and Mark Philip curve demonstrating the effect of increasing preload on stroke volume and lung water in a patient who is preload sensitive and responsive and non-responsive with sepsis. And you can see how the large increase in cardiac output is small increase in EVLW, and then you have a large increase in EVLW, large increase in filling pressure. So this is just going back to our old physiology. What's going to happen with the fluid overload? To summarize, you have increased bowel edema, you can have bacterial translocation, endothelial damage because of the glycocalus damage, needs capillary leak, decrease in intravascular volume. You have a stretching of the atrium and the blood vessels, cause A and B release. You have renal congestion and interstitial edema that impair the metabolites diffusion and compromise on renal oxygenation, decrease in renal perfusion. We have combined the renal angina index with a fluid overload. That's last slide that I showed the calculation. Then there's an increase in intra-abdominal pressure, microvascular flow get compromised. You have increase in the intra-abdominal pressure, which causes decrease in cardiac output, rise in level of catecholamines, renin, angiotensin, and inflammatory cytokines, which again causes the acute kidney injury. Such a vicious circle of just primary one index, if you look, that was fluid overload. This is very well depicted in the setting of acute kidney injury after bone marrow transplantation. If you look, these patients are set up for the chemokine burst, fluid overload, and also by priming it with various kind of total body radiation, pre-bone marrow transplant chemotherapies given to them. And this is our guideline, which is just recently got published from the PCRRT iconic group. Again, an example of international collaboration from all parts of the world. And it shows how you can trigger the AKI and how you can prime these patients for a capillary leak. And also with sepsis chemotherapy, how this further deteriorate the outcomes. Now, this is my paper again about the advances. We have worked on various kind of cytoskeleton breakdown, loss of polarity, apoptosis, necrosis. Dr. Devarajan must be presenting this. He will show you there's a lot of things happening after the normal epithelium damage to kidney failure and then regeneration. Maybe this is a time where we have to act, where you have decreased perfusion, hemodynamic perturbation. This 6 to 8 hour is so important before there is a complete damage. You have start necrosing these tubular cells. Maybe here we have to act. Maybe we have to stratify these patients with fluid overload. Look into the FST. This is furosemide stress test, which I'm going to discuss. Renal reserve. Assess the patient. Assess the patients who are at risk of developing AKI. This paradigm, this is crucial time, needs to be looked and worked upon. As you can see that the fluid overload administration between enrollment of 72 to 90 days, mortality in control of early goal-directed therapy, reverse Janssen process, arise and promise. Again, 3 days are so crucial, and more the fluid overload, higher is the mortality. Now, fluid overload and adverse outcome. Does current evidence endorse causality? Going back to my primary question. If you look into the post-hoc FACT trial showed fluid overload as a causal intermediate in the association between diuretic administration and decreased mortality in AKI, suggesting that the mortality benefits associated with furosemide was due to decrease in the fluid overload. For pediatric studies have in fact shown that fluid overload is significant comorbidities highly associated with the outcome. And you can actually stratify the mortality, morbidity on the basis of the assessment of quantifying the fluid overload. I'll show it in the slide. This was there, and maybe in adult it was shown, but it's not recognized. If you see this study, which was published by Gwinning in Kidney 360, 90-day mortality by 72 hours volume status with RRT and without RRT, no volume load overload versus volume overload, huge difference in the proportion of the mortality. If you look in the patients of the effect of volume overload and RRT on survival, the 90-day curve for patients stratified by the volume overload at 72 hours after ECMO cannulation and RRT status, you can see the patients who have overload, volume overload, and on RRT, worst outcome. And also immediately after that is the patients who have overload but no need of RRT. Just above that is no overload, only RRT, and just above that is no overload, no need of RRT. So again, if you have a patient with fluid overload on RRT, the mortality is higher. Fluid overload is associated with impaired oxygen and morbidity in critical care patient, and this has been shown on the day of PICU admission and cumulative fluid overload percentage, and you can see the oxygen index in first 5 days. And we have also shown that the renal angina index with fluid overload, there is impaired oxygen index, as both of them, if RAI is more than 8 and you have fluid overload mainly around more than 10%. Is fluid overload ever independent of AKI? There's a fact study show that presence of covert AKI was independently associated with high risk of death. Incidence of AKI was greater in a conservative arm before adjustment, but in liberal arm post-adjustment. If you look into the Picard study, it revealed that correction for a fluid overload uncovered misdiagnosis and reclassified AKI in some patients. Basu and his group find out that 92 infants undergoing arterial switch operation where in correction of serum creatinine for fluid overload not only increases AKI prevalence, but also strengthened it, also prove its association with the post-operative morbidities. It is bad. Fluid overload is independently is bad. There are multiple studies, but just to highlight, if you have a fluid overload in a CRRT patient, less than 10, mortality is 30%. If you have fluid overload 10 to 20%, 44%, 66% in the setting when you have fluid overload more than 20%. Kidney replacement therapy, when you talk about it, KRT provide control and fluid management and allow for ability to achieve negative fluid balance. And this is some of the studies I want to emphasize here. Fluid overload at CRRT initiation was associated with raised order of mortality after controlling any severity in legs, with maximum risk noted in a patients who have fluid overload more than 20. If you look into the renal study, which is a randomized evaluation of normal versus augmented level of renal replacement therapy, showed that negative mean daily fluid balance was significantly associated with reduced mortality and increased RRT free days. Non-survival CRRT recipient in the PCART study also had a significant higher fluid load at the time of initiating the CRRT. If you look into the subsequent reanalysis, highlighted for the first time increased risk of sepsis in patient with AKI, authors speculated that fluid overload comprises epithelial integrity by causing gut edema, thus favoring bacterial translocation. Fluid accumulation, survival, and the recovery of kidney function in critically ill patient. No fluid overload versus fluid overload. You can see the survivor and number of survivor days, huge difference. Adjusted odd ratio for death of fluid overload at RRT initiation 2, 95 confident intervals 1.2 to 3.37. Percentage of fluid overload at CVVH initiation, see the survival versus non-survival. And they're all getting the CVVH. What was thought in 2001 evolving into 2002-3 when the data was coming out, it is possible that in some case of CVVH or D, maybe prevention rather than the treatment for worsening degree of fluid overload. Early initiation of CVVH to allow for sufficient blood product and nutrition administration while preventing fluid overload may improve patient survival. The thought was there and it evolves in 10 years. Fluid balance of pediatric hematopoietic stem cell transplantation in ICU, more than 10%. You can see the difference between the RRT and fluid overload response. Indication for CRRT initiation fluid overload in 39%, which is our pediatric retrospective study from CRRT registries have shown. Again, fluid overload after continuous hemofiltration, survival and critical year patient. You can see the difference with MODS, more than 3 organ MODS. Again, survival versus non-survival. See the cumulative fluid overload, 15%, 15.5 worse outcome as compared to non-survivors, 9.3 to 9.2. Fluid accumulation, survival and recovery of kidney function in critically ill person with acute kidney injury, again, the jury is out. 2, odd ratio is around 2. If you see a positive fluid balance is associated with worse outcome in patient with acute renal failure, early AKI, late AKI, no AKI. Again, the fluid overload was bad. And the mean fluid balance per liter per 24 hours hazard ratio was around 1.21. Fluid accumulation, survival and recovery of kidney functions with acute kidney injury, again, fluid overload is bad. The ratio is around 2. Comparison of 2 fluid management strategy in acute lung injury. This was a study which was done when I was a fellow for the ARDS clinical network. You can see in conservative and liberal, ventilation-free days were 14 versus 12, ICU-free days was 13 versus 11, RRT day was 10 versus 14. There was no mortality difference, but again, if you see about ventilation-free times, ICU-free days were better in the conservative arm. That opens up the whole concept of 2002 and 3 evolving, which I have published a beautiful article. This I thought I would do it when I would retire, but I did it very early in my career, changing the terminology from kidney replacement therapy to kidney support. Because we don't have to wait for the replacement in life-threatening indication, acidemia, hyperkalemia, pulmonary edema. Maybe we need for volume control, manipulation of cytokine. Good example, COVID-19. Solute modulation, cancer chemotherapy, respiratory acidosis, and I will highly recommend the fellows to read. I have justified the need that RRT is not replacement. Now you should change the concept to renal support. What a good example of that is the paper we published for the veno-occlusive disease. As you can see, when the patients are more than 5%, we consult nephrology algorithm. The algorithm is consult nephrology, concentrate the fluid, consider furosemide infusion. If it is more than 10% despite that, transfer to the PQ and consider a CRRT. And I just want to let you know that the patients who have managed to respond well with the furosemide and maintain between 5 to 10% of their fluid overload, they did better. Patients who are more fluid overload despite failed diuresis on CRRT, the mortality was high. Patients' chemical balance in CKRT, we can equilibrate the blood through the dialyzer. We can do convective therapy. Loss in isotonic volume can be replaced. The whole CRRT is evolving. We have new machines. We have HF20. We have now Carpe Diem. Things are going up. Again, you have to always understand what Tim says, that solute and effluent flow rate is limited and limiting factors in CKRT. So and this is another very beautiful article I have looked into, precision of fluid management in continuous replacement therapy. What you have proposed, what patient is, you need to balance it out. If this is a patient who has positive fluid balance and this is what machine is delivering, you want to make sure that they will equilibrate at certain point of time. You need to do a 12-hour assessment, 6-hour assessment, 1-hour fluid. So you move on hourly to 6 hourly to 12. You have to be very careful to precisely make sure what you are delivering through machine, how you are dealing with the patient. You don't want this bubble to merge into, they should be equilibrium, they should come into equilibrium parameters. You should maintain the fluid balance and maintain with the CRRT, and you don't want to go overboard and do not underdo the justice. How can you have a principle of fluid management and CRRT? You should have four things that you can control. You can control the ultrafiltration, which removes fluid with composition close to plasma water. Then you can replace it through the composition of replacement of fluid, which can be changed. And you can have a CRRT fluid balance, which I was talking about initially. Make sure what you are taking out in and out. If patients are fluid overload, make them negative. And then have a patient fluid balance. You want to match what you are delivering, what patient condition is, and difference between all intake, output, including CRRT for any given period of time. Key updates: fluid therapy is integral to the acute resuscitation of critically ill patient. Threshold may exist beyond which the perceived benefit of additional fluid therapy after resuscitation may contribute to harm. Prevention of fluid overload is so important, and prevention and early control of fluid overload is evolving as a primary trigger for RRT. Again, renal replacement to renal support. Some of the other update, it is important to recognize fluid overload early. Management of fluid overload in AKI may differ, whether the patient is oliguric or non-oliguric. Fluid overload more than 10% is associated with increased mortality. Fluid overload is a symptom and a biomarker rather than stand-alone condition and require multi-system assessment and intervention. The goal of managing patients with fluid overload is to maintain a daily negative balance. When considering an approach to treat fluid overload in a patient with AKI, the first step is to identify the patient is oliguric or non-oliguric. If you have a non-oliguric AKI, determine the negative balance fluid goal for the day. Total output, fluid minus fluid intake. Goal is negative fluid per day. The negative fluid balance goal is determined based on the size of the patient, what is the hemodynamic stability, degree of fluid overload, and respiratory status. It should not exceed 5% of the total body weight by 24, although safe rate remains unknown and might be lower than this threshold. Monitor fluid intake and output closely and adjust fluid intake as needed. Monitor electrolytes. If you are in an oliguric AKI, fluid restriction. This will help avoid progressive fluid overload, often lead to inadequate nutrition. Insensible fluid loss plus ongoing losses, urinary, GI, respiratory, will maintain even fluid balance starting point for your fluid intake. Insensible fluid loss calculation per day needs to be taken on. And now this should be in your medication tab. You talk about other parameters, this should be your medication tab. You should be assessing this daily because you don't want to see them after 7 days when you have a fluid overload more than 40%. Management of fluid overload under medication tab. People say that loop diuretics are usually the first choice. Furosemide is the best used agent. And there's a new concept evolving now, which is a furosemide stress test. And where the renal reserve test in oliguria by assessing urine output has been proposed in adults to determine the progression of severity of the AKI. Now, if you look into any studies which assess the effect of diuretics in AKI and mortality, the data is there is no difference in the effect of AKI or renal recovery if you give diuretics. And actually, if you look Mehta et al. Study, which has shown the mortality, the odds of getting death with diuretics use are higher. So the jury is out, but you have to start with a loop diuretic as a first choice in this critically ill patient, so you at least catch up these fluid overload over the time. Be careful when you're giving Lasix because these patients, as I said before, they're sick. There's a loss of epithelial cell polarity, oliguria, urea, uremic organic acid accumulation, severe metabolic acidosis, hyperlipidemia. They have a tubular damage and destruction. So the OAT1, 3, and OAT4 transporters are secretion in urines are elevated. So some of the time, these furosemide does not reach to the tubule and you will not get an adequate response. Now, this is what about the sodium potassium chloride channel. As we all know in nephrology, this is a highly required, highly oxygen sensitive and highly utilized oxygen channel. And this is what you do in AKI 1 or 2, you give furosemide challenge dose, and after 2 hours, you see what was the response, whether volume was more than 200 or not. This is mainly the adult study. And what we call this furosemide stress test, you can do that in critically ill patient with early AKI. And the study, the performance of FST to predict the primary outcome was robust and consistent in both cohorts with a range of AUC of around 0.82. Patients should be euvolemic before undertaking any type of furosemide challenge, and volume replacement is mandatory in patients who are not obviously volume overloaded. FST should be conducted in an appropriate clinical setting where urine output, heart rate, and blood pressure can be monitored. So this is just something growing up. We talked about renal reserve test with a protein load. In summary, fluid accumulation is bad, contribute or worsens AKI and multi-organ dysfunction, short and long-term injury to the non-renal organs, increased mortality, morbidity, and poor outcome. Need to better understand the ideal way safely mitigate or remove excess extracellular. COVID-19, the worst way to learn the pandemic. And this is what was a challenge in the patients who are coming with ARDS. And this is our paper which we have published, the guidelines of the COVID-19, where we have used high flow in these patients to remove the chemokines, assess the fluid overload, work on the cytokine storm. Various filters are coming into the place, and it is a global health problem. And if you have a patients with like a congenital heart disease, repair, cystic fibrosis, they go into COVID-19. You're dealing with both fluid overload, chemokine burst, you're dealing with the ARDS, and this is what we have learned in pandemic, and maybe the fluid overload is also integral in these patients. This is a review in blood filters with COVID-19 and AKI, and you can see the most detrimental factor was actually, if you look around, was the volume overload in ARDS. In adult, we have used the auxiliaries, which is the absorption mechanism, and we have a better response removing the chemokines and adjusting the fluid overload. And this is how the transition of the medicine is going in AKI. Who believe that chemokine hypothesis? Who believe that IL-6 can be removed and can be helpful? Example, COVID-19. Who believe that fluid overload will be such an integral part? COVID-19. By the time I see the patients in the ER, they come, they are on BiPAP, they go into the respiratory failure, immediately on ECMO. So this is what COVID-19 has given us the platform. And actually now the people should think about and rethink about AKI definition, bring into the parameters of various urine biomarkers, clinical biomarkers, furosemide stress tests, renal angina index. Various things need to be combined so we can develop a precise model for the patients who are predicting AKI. Again, advances is going on. This is our paper in AJKD, ACKD, where we talked about these smaller machines now. There's no issues now in the neonate. So fluid overload in neonate is bad too. We have shown it in our Awaken study. We have multiple smaller gadgets now to prevent. This is an evolution in AKI CRRT. What is my vision? And, and I graded them, but it's maybe wrong or it may be right. For the approach to the fluid delivery and meticulous approach to the output with routine surveillance of percentage of fluid should be a part of daily assessment. That's what I think. It's 1C. I will give the recommendation. Just go into parsimonious approach. What is going in, going out should be in your medication. Net fluid balance as a difference of in-out should be routine, in addition to common practice of addressing urine output adequacy through the convention of ml per kilogram per hour. Again, I gave that 1C. This is just my wish. Although prospective demonstration of adherence to the total fluid rate goal has yet to be validated, the converse, which is unrelenting increase in the fluid accumulation, appear to be associated with negative outcome. Therefore, routine adjustment of source of fluid in, which is maintenance fluid, carrier fluid, non-nutritive fluid, medication, blood products, may be considered. Target net fluid balance goal per day should be stipulated. Whether casual or associated, the relationship between fluid overload and poor patient outcome appear consistent, dose dependent, and direct. CRRT may be considered when fluid overload is more than 10% with worsening AKI or worsening respiratory status or increase in inflammation, or if you have diuretic resistance. This is what I personally feel for the fluid overload, being more passionate. But again, you can take this at your setting, in your setup, but this is just a nice lecture to show where we are, where we are moving, and how these, what we call as a feather approach, looking into these parameters of fluid overload, renal angina index, AKI biomarkers, furosemide stress, these are all growing, but these all puzzles need to be put together. And maybe we need to develop a precise model where we can have a good idea which patient may go into AKI, which will go to AKI with worsening respiratory status, which AKI patients will be needing an RRT. We are just, I would say this is just a start, but being an adult and seeing more COVID-19 using various extracorporeal therapy, maybe this is a start of a new era, a new research, and maybe we will be talking in the same conference 5 years down the road with some kind of model, and that's what I envision. With that, I want to thank you, and I'm open for any questions.